All right, today we are diving deep into valvular heart disease. We're going to get into the core mechanics, talk about the critical numbers that literally guide life-changing decisions, and map out the clinical pathways that can alter a patient's entire future. Let's get right into it. So here's the big question that really frames this whole discussion. In cardiology, the difference between let's watch and wait and we need to operate now can come down to measurements that are just tiny. We're talking about a valve area smaller than a postage stamp or a chamber dimension that's off by just a few millimeters. Getting these right is, well, it's everything. So let's start with the absolute fundamentals. Every single complex valve disease, it doesn't matter which of the four valves we're talking about, it really just boils down to one of two basic mechanical problems.
Okay, so on one hand, you've got stenosis. The best way to think about this is like a rusty, narrow door hinge that just won't open all the way. The heart has to build up this immense pressure just to force blood through that tiny opening. Then, on the other hand, you have regurgitation. This is like a leaky seal on a pipe. The valve just doesn't close properly, so blood leaks backward. This forces the heart to handle a much bigger volume of blood with every single beat. So you see, it's pressure overload versus volume overload. That's the fundamental split.
So how do we actually see these problems? Well, that's where echocardiography comes in. It is, without a doubt, the gold standard tool. Using ultrasound, it lets us look right at the valve structure, see how it's working, and measure all the hemodynamic consequences. Things like how fast blood is flowing, the pressure gradients across the valve, and the precise valve area. All those critical numbers we're about to talk about, they come directly from the echo. Now, let's focus in on the left side of the heart. This is the high-pressure system, the one that pumps oxygenated blood out to the entire body. So it's really no surprise that the aortic and mitral valves are where we find the most common and most clinically significant problems. And we'll start with the most common valve disease out there, aortic stenosis. Most of the time, it's a disease of aging, just a slow buildup of calcium over the years. But it can also show up in younger patients who were born with a bicuspid aortic valve instead of the usual 3 leaflets. This is our classic rusty hinge problem. The left ventricle has to work so much harder, and its muscular wall literally thickens as it fights to push blood through that narrow opening. And here they are. These are the make-or-break numbers you have to know. A valve area less than 1.0 square centimeters, or a mean pressure gradient across the valve of over 40 millimeters of mercury. When you see these numbers on an echo report, you have officially diagnosed severe aortic stenosis. This is the hard data, the objective evidence that this valve problem is causing a major backup in the system. But the numbers are only half the story. The real turning point, the game changer, is when symptoms show up. Once a patient with severe AS develops syncope, that's fainting, angina, or chest pain, or dyspnea, which is shortness of breath, that's the classic SAD triad. Once that happens, their prognosis gets dramatically worse. It's the heart's way of screaming that it can't compensate anymore, and it's a clear signal for intervention, like a valve replacement. Okay, moving from a valve that won't open to one that won't close, we have aortic regurgitation. Now we're back to that leaky seal. Blood is flowing backward into the left ventricle while the heart is trying to relax and fill. This creates a massive volume overload. And over time, this causes the left ventricle to dilate, to stretch out, as it tries to accommodate all that extra blood. For aortic regurgitation, we're laser-focused on a key measurement that shows us what that leak is doing to the heart muscle itself. It's the left ventricular end-systolic dimension, or LVESD, and a number greater than 50 millimeters tells us the ventricle has stretched out to a critical point. So why does this matter so much? Because even if the patient feels totally fine, this number is a trigger for surgery. It tells us we have to intervene to prevent irreversible damage to the heart muscle. Now let's shift from the aortic valve down to the mitral valve, where we find mitral stenosis. The number one cause of this worldwide is a history of rheumatic heart disease, which leads to scarring and fusion of the valve leaflets. On an echo, this creates this classic doming or hockey stick look, and this blockage causes a huge backup of pressure into the left atrium right behind it. And just like with aortic stenosis, there is a key number to remember. For the mitral valve, a valve area less than 1.5 square centimeters is what defines severe disease. This level of obstruction is what drives all the symptoms and downstream problems, like atrial fibrillation and pulmonary hypertension, because all that high pressure from the left atrium starts backing up into the lungs. And finally, for the left side, we have mitral regurgitation. This is another volume overload problem, but this time blood is leaking backward from the powerful left ventricle into the left atrium when the heart contracts.
This makes both the left atrium and the left ventricle dilate over time. And again, we watch that LVN systolic dimension very closely, but with a slightly different threshold. Here, over 45 millimeters is a trigger for surgery.
And here's a really quick but vital management principle for MR. Whenever it's technically possible, repairing the patient's own valve is much, much better than just replacing it. This almost always leads to better long-term outcomes for the patient, and it avoids the need for lifelong blood thinners that come with mechanical valve.
Okay, so we've covered the high-stakes players on the left side of the heart. Now let's pivot and take a look at what happens on the lower pressure right side.
So diseases of the tricuspid and pulmonary valves are generally not as common, and very often they're secondary. What that means is they're usually a consequence of problems happening somewhere else, like pressure overload coming from the left side of the heart or from the lungs themselves.
Let's just do a quick run-through of the right-sided issues. The most common one, by far, is tricuspid regurgitation, and it's usually functional, which means the valve itself is actually normal, but high pressure in the lungs has stretched out the right ventricle, pulling the valve leaflets apart. In stark contrast, pulmonary stenosis is almost always congenital, something a person is born with. Tricuspid stenosis is super rare, and it's typically linked back to rheumatic disease. And finally, pulmonary regurgitation is often seen years after someone has had surgery for other congenital heart defects. The big takeaway here is that for right-sided disease, especially TR, you often have to treat the root cause, like the pulmonary hypertension.
Of course, in the real world, things aren't always so perfectly neat and tidy. Patients can have issues with more than one valve at the same time, or they might already have an artificial valve from a previous surgery.
For these more complex cases, there are two key principles. With mixed valve disease, let's say someone has moderate aortic stenosis and moderate regurgitation. Your job as a clinician is to figure out which problem is really driving the patient's condition. And for prosthetic valves, if you suspect there's a problem, like a clot or an infection, a standard echo just might not give you a clear enough picture. You'll likely need to use a transesophageal echo, or TOE, to get a clear, unobstructed view right from behind the heart.
All right, let's boil all of this down into the most practical, high-yield points, the things you can take and apply directly in a clinical setting or when you're staring down an exam question. Here is a hugely important clinical rule of thumb. If you hear a murmur in a patient, and that patient has symptoms of heart failure like shortness of breath or swollen legs, the next step is always an echocardiogram. No hesitation, no second thoughts. From there, your job turns into a bit of detective work, using all the clinical and echo clues to figure out exactly which valve is the culprit.
So this clinical pathway is really simple and totally repeatable. First, you identify the problem at the bedside. You hear a murmur and the patient has symptoms. Second, you order the essential tool to see what's going on, the echo. And third, you interpret the data from that echo, all those key numbers we talked about, to diagnose the specific valve problem and grade how severe it is. And that is what guides your entire management plan.
We'll end with a final thought to chew on. With the rise of less invasive procedures like TAVR and transcatheter mitral valve repair, the whole landscape of treatment is changing. The risk-benefit calculation for when to intervene is shifting right before our eyes. So it begs the question, as our technology makes treating these diseases safer and more accessible, how will our rules, our thresholds, and our guidelines have to evolve? That, right there, is the question shaping the future of cardiology.